Since 1955, the United States government has been aware of the dental disparities faced by Native Americans. With the creation of Indian Health Service, attempts to reduce this disparity have been made with limited improvement. Today, we still have wide discrepancies among dental health in America, with Native Americans consistently ranking highest in dental decay and gum disease compared to other races. Tribes struggling for clean water, rural living conditions, staffing shortages, and slow adoption for solutions are contributing to dental care disparities of adult Native Americans. Dental diseases include cavities, gingivitis, periodontal disease, oral cancer, abscesses, and the result of tooth loss. These can lead to chronic systemic diseases. Links between periodontal disease have been found with diabetes, preterm labor, low birth weight, and Alzheimer's disease. Native American adults had 2 to 3 times as much untreated dental decay as the rest of the United States, and almost twice as much periodontal disease rate. Through research in multiple articles, this graph shows dental disparities among races, highlighting the rate of untreated decay among Native Americans. Environmental factors, socioeconomic status, and historical and cultural influences all negatively impact dental care. The sheer environment of living on a reservation has many influences. Rural reservation land limits access to dental care services through transportation, food deserts, and access to clean water. This map is an example of the Standing Rock Indian Reservation in North Dakota. Black dots correspond with major towns located on the reservation. Majority of residents must travel 20 or more miles away for dental care. Native Americans living in Bismarck-Mandan metro area, off of the reservation, may travel 70 or more miles for Indian Health Service dental. The red dots indicate stores with food, although most are convenience stores with limited fresh foods. Both reservations and minority neighborhoods typically consist of food deserts, with limited access to food and fresh produce. Dollar General and Family Dollar are 2 types of stores often found near reservations. Clean water has been an ongoing issue for many tribes. Water contamination and poor water infrastructure contributes to lack of brushing, lack of water consumption, and may contribute to greater unhealthy beverage consumption, leading to dental decay or diabetes. Specific examples of water concerns include the Navajo Nation, various Nebraska reservations, Warm Springs, Oregon, Pine Ridge, South Dakota Reservation, and various California tribes. With limited access to water, this disproportionately affects individuals of lower socioeconomic status. This can be seen through the poverty cycle. Generally, Native Americans have lower socioeconomic status, resulting in greater dental disparities due to inability to afford transportation, lower rates of educational attainment correlating with lower health literacy, reducing the knowledge of dental disease and prevention. Lower median household incomes, higher rates of poverty and unemployment contribute to lower socioeconomic status of Native Americans. This prevents the ability to afford higher education to obtain greater social position and afford dental care. Lower socioeconomic status leads to poorer childhood dental health. Native American children have 2 to 3 times as many dental caries than other races. This leads to inability to focus in school, poor academic success, low self-confidence, and misinformation about dental health importance. With lower socioeconomic status comes lower educational attainment. Only 17% of Native American students pursued secondary education after high school. Lower education reduces ability to obtain a job with health insurance, reduces dental health literacy, and can contribute to staying within the poverty cycle. Poor dental health and limited dental care throughout life occurs due to lower socioeconomic status, preventing ability to afford care and education. Chronic dental pain can affect job performance and job outlook depending on appearance of teeth in public positions, resulting in unemployment. I was able to discuss dental concerns from the viewpoint of Clay Byington, member of the Standing Rock Sioux Tribe and employed as a dental assistant. Hello, Clay. Thank you for agreeing to interview with me in regards to Native American dental health disparities. Can you please introduce yourself for the class?
Hi, my name is Clay. I'm a member of the Standing Rock Sioux Tribe. I'm a dental assistant. I've been a dental assistant for about 6 years. Spent 3 years at the Standing Rock Indian Health Service on the Standing Rock Indian Reservation, and 3 years most recently with the Department of Veterans Affairs in Minneapolis.
And then when you need dental services right now, where do you typically seek your dental care?
I seek my dental care at a tribal clinic here in Minneapolis that they call it an Indian Health Board. It's a Section 38 dental clinic operated through the Department of Health and Human Services.
And then from your experience as a patient, can you describe any issues that you may have encountered when needing dental services as an adult?
Dental services as an adult, the biggest thing would be staffing in community care clinic settings. More patients tend to go in to get an issue fixed, a dental treatment, and the clinics are so focused on a single treatment option for a patient to get them out of pain that they don't take a whole mouth approach to getting their teeth fixed.
So there's kind of been a lack of comprehensive treatment planning when you've gone?
That's correct. And then it just creates a problem for the whole patient base. You'll see a lot more patients go in and get root canals started, temporary fillings put in. They return in a year.
Do you currently use dental insurance provided by your employer?
I do.
If you didn't have dental insurance, would you have access to tribal health or IHS services or not?
In a very limited manner, I would. If I lived on the reservation, everybody within the boundaries of an Indian reservation has access to dental care. Of course, when you're on a reservation, and if you're impoverished, then it becomes more of a lack of transportation to get dental care. In an urban setting, yes, the community clinics, do a good job of providing care. They do usually a sliding fee scale, and they really work with people to help them.
Since you mentioned transportation, what's the furthest you have ever traveled for dental services when you were seeking tribal or IHS care?
The furthest I've ever traveled, 45 miles to the nearest clinic. That was the community clinic I worked at, and that's where I received care. In more rural areas like North and South Dakota, a lot of patients do travel hours to get to these facilities. I remember in the old community clinic I worked at, we had patients that would come from neighboring tribes and, just to receive this care. We had a few come from the Turtle Mountain and MHA Nation tribes, just because they didn't have a pediatric dentist in those areas.
That's significantly impacts here for sure. When considering historical and legal factors, Native Americans are the only population that is determined by blood quantum levels. Additionally, Native Americans have not been adequately represented throughout history. During research for this documentary, Native American health was often left out. Historical mass trauma inflicted upon by the government has created distrust in government-run organizations and generational trauma through adverse childhood events like boarding schools. Disparities continue to grow due to lack of trust through community partnerships and lack of cultural sensitivity. Training should include acknowledging past traumas such as forced assimilation and genocide and differences among tribes. Knowledge of traditional diets versus modern high glycemic carbohydrate foods have contributed to high rates of decay and is exacerbated by food deserts. Family structure is important for addressing dental care, and all family members need to be included. Indian Health Service, a government solution, has provided dental care to some health clinics, but understaffing, federal budget, and location pose major issues for Native Americans. Weakness of government intervention include wait time, travel distance, and transportation, in addition to sustaining safe drinking water. Newer solutions for addressing dental disparities include using HRSA and National Health Service Corps to provide incentives, like loan repayment, for dental professionals to reduce turnover and increase staffing. I was able to discuss solutions for dental disparities with Clay. Looking at solutions for improving the care among Native Americans. And two ideas that I thought of was implementing dental therapists on reservations or in community health centers, and also potentially improving programs at tribal colleges to include dental programs like dental assisting or dental hygienist. Do you have any input on if you think either of those solutions would be helpful?
Definitely. I think that regulating and helping implement like academic programs for dental assisting and dental hygiene would be very beneficial to Indian country. Indian country referring to all 500 plus tribes there are, but definitely like on Standing Rock for a specific example, there's a tribal college, and one thing that they always need there and across North Dakota, South Dakota is dental assistants, and not only on tribes but in the rural areas, very desolate, and it's just, these programs would really help get more of a workforce out there. And I think that it would really be beneficial and specific to Native Americans because they would be taking them straight from high school and training them and getting them, that associate's degree in dental assisting.
And then anything to add about dental therapists from what you know?
Dental therapists, that would be another great option. It's been successful in Minnesota, Washington, places on the West Coast. As far as in tribal nations, I think that would be great. I don't know why policy doesn't exist now that doesn't permit that. I think that would be more of an urgency than anything. They should have that boarded as like a, as a federal job, for Indian Health Service centers. But one thing, I don't know if tribal colleges have the capability to do dental therapy programs. However, I could see it happening if they had a hygiene program. But I could see, like maybe bigger universities in North Dakota offering that also. Overall, just for like a rural, for the rural issue at whole.
One solution discussed with Clay was the idea to increase the Native American dental workforce. Seneca Nation Health System and the University of Buffalo School of Dental Medicine are directly addressing the lack of Native American dentists by creating the Native American Pre-Dental Student Gateway that encourages students to pursue dental careers. Another solution discussed were mid-level providers. Dental therapists and dental health aid therapists, or DHATs for short, are being utilized with tribal health to bridge access to care issues. This new position is allowing for dental providers to be employed at a lower cost and provide both hygiene and simple dental services under general supervision. This map shows current adoption of these mid-level providers. Unfortunately, there is a lot of controversy surrounding these positions, and without state dental board approval, federal clinics cannot utilize these positions. Pew Charitable Trust has ongoing efforts lobbying toward dental therapists and DHATs to help reduce dental disparities. Mobile dental clinics and buses are great options for improving the access of dental care for Native Americans. With mobile dental clinics, dental professionals can travel to different rural areas to reduce need for transportation. Additionally, utilizing mid-level providers can help provide greater care at a lower cost. Due to lack of studies on Native American oral health, an increase of understanding among all dental providers regarding cultural sensitivity is necessary. Delivering culturally appropriate care will improve patient-provider rapport. Developing dental programs within tribal colleges can increase the percentage of Native American dental staff. This can strengthen the quality of care as well as provide greater job opportunities of higher socioeconomic status. With the adoption of mobile dental services, traditional dental clinics can be transformed into specialty dental clinics with rotating dental specialists to provide care closer to home. Additionally, partnerships built within private practices of metro areas should be developed similar to how the Veterans Health Administration provides care in the community, which is budgeted funds for individuals who live beyond 60 minutes from a VA facility. Native Americans living beyond 60 minutes from IHS dental facilities could be provided care from non-IHS facilities closer to home. Lastly, as all tribes are different, incorporating community leaders with community-based participatory research, we can identify areas of need within each tribe regarding dental disparities to create interventions that will be successful and maintained. In conclusion, dental health disparities among adult Native Americans can increase risk for systemic disease, lead to poor health, and prevent job obtainment. By increasing the dental workforce to include greater diversity and mid-level providers, create mobile dental clinics, and improve water infrastructure, we can reduce these dental disparities and work toward comprehensive dental care.